Hello, my name is Dr. Alexander Pearl, and I'm a leukemia faculty member at the Abramson Cancer Center of the University of Pennsylvania. This presentation is on targeting FLT3 mutations in AML, and specifically the difference between first and second generation FLT3 inhibitors. Mutations in the hematopoietic cytokine receptor tyrosine kinase FLT3 are among the most frequent mutations in AML, occurring in approximately one-third of patients at initial diagnosis. These mutations activate the receptor's tyrosine kinase, causing dimerization, constitutive activation of a series of intracellular signaling proteins, which lead to anti-apoptotic, pro-survival, and proliferative programs. They also contribute to differentiation block in AML. There are two major kinds of FLT3 mutations. The FLT3 ITD mutations are both the most common and the most sinister. They occur in anywhere from 25 to 30% of patients and are associated with higher relapse rates and generally poor prognosis. FLT3 tyrosine kinase domain mutations at D835 are associated with aggressive disease biology, but not a higher relapse rate. The overall survival of patients with FLT3 mutations as compared to patients without FLT3 mutations is shown on this Kaplan-Meier curve from a German cooperative group trial from early 2000s. As you see, FLT3 ITD has a worse prognosis than either patients with wild-type FLT3 or D835 tyrosine kinase domain mutation. And because these mutations activate a tyrosine kinase, there have been a number of drugs developed to target the kinase, including early drugs which were multi-kinase inhibitors, such as midostaurin, listortinib, and sorafenib, and more recently developed drugs that have higher potency and greater selectivity against FLT3 itself. These include quizartinib, crenolanib, gilteritinib, and FF10101-01. I'm only going to mention the last drug in passing because it is undergoing early testing. The other drugs have all been through phase 3 testing in AML. Looking at kinome scans for the various drugs' activity against the entire human kinome, we can see that the first-generation drugs shown on the left were relatively non-selective in terms of their activity against various different kinases, whereas the second-generation drug, quizartinib, shown on the right, really has a small spectrum of activity against receptor tyrosine kinases, indicated by the arrow, and relatively little off-target activity. One can also see that the potency of these drugs in a test tube is quite good and relatively similar across the drugs. However, in human plasma, there's variable binding to human plasma proteins, leading to quite low levels of free drug for the early multi-kinase inhibitors, and the more recently developed drugs have greater bioavailability, meaning lower concentrations of the FLT3 inhibitor are needed in order to inhibit the kinase. That can be seen for the bottom three second-generation drugs. Because of the kinase non-selectivity and also unfavorable pharmacokinetics, there is a limited ability to dose escalate first-generation FLT3 inhibitors to really high doses that would be needed to potently inhibit FLT3 throughout the dosing interval, as was predicted to be necessary for optimal anti-leukemic effects in patients. There also are significant drug-drug interactions between some of these drugs and, say, azole antifungals. And as single agents, the first-generation drugs had relatively modest activity against leukemia. They did cause peripheral blast reductions or elimination in patients with FLT3 mutations, but this also occurred in patients with wild-type FLT3, and it was not clear that the drugs really had a selective advantage in terms of treating patients with FLT3 mutations. Marrow responses had relatively modest reductions, if any, in the blast percentage, and any anti-leukemic effects were quite short, measured typically in weeks, before patients developed progressive leukemia. So we don't actually have a lot of data to say that first-generation FLT3 inhibitors in the relapse refractory setting have much activity on their own. By contrast, second-generation drugs do have single-agent anti-leukemic effects that can be measured both in terms of elimination of peripheral and extramedullary blasts and also reductions in marrow blasts, in many cases to less than 5%. Varying amounts of hematopoietic reconstitution was seen with these drugs, which were given tonically without breaks, and so the predominant response to the second-generation FLT3 inhibitors is a CRI, which has incomplete blood count recovery, but less than 5% blasts in the marrow and no circulating or extramedullary blasts. As you can see, the drug quizartinib achieves a composite CR, meaning any CRI, CRP, or CR, in approximately half of the patients, with perhaps a quarter of patients also showing partial remissions. As you note here, that was not particularly affected by the dose of the drug, even though higher doses of the drug beyond 30 or 60 milligrams did have higher toxicity rates in terms of prolongation of QT interval. We do have data on first-generation FLT3 inhibitors, not so much as single agents, but in combinations, and initially the data were quite disappointing because the addition of this FLT3 inhibitor, listortinib, which was a multi-kinase inhibitor, to salvage chemotherapy failed to improve the survival of patients treated for first relapse with either high-dose Ara-C or mitoxantrone etoposide and intermediate-dose Ara-C. As you see, the median survival of these patients was quite short, less than 5 months, and relatively few patients proceeded to transplant, which is the only known cure for this population. Using these drugs in frontline combinations, particularly studies of sorafenib or listortinib, also failed to show improvements in overall survival. Although the sorafenib addition to frontline 7 and 3 and high-dose Ara-C post-remission therapy did improve event-free survival, with the caveat that a relatively small number of patients with FLT3 ITD mutation were enrolled on this trial. However, more recently, data looking specifically at FLT3 mutated patients and using the drug midostaurin indicated that the addition of midostaurin to frontline 7+3 induction and post-remission high-dose Ara-C improves the survival of patients who are newly diagnosed and have FLT3 ITD or FLT3 TKD mutation. Most notably, there were improvements both in terms of the overall survival of the population and the patients who went to transplant in first remission, who still showed a benefit from midostaurin over standard chemotherapy, regardless of the fact that these patients were in remission at the time of first CR transplant. So what do these results mean for those treating patients with FLT3 mutated AML? First and second generation drugs differ in their degree of FLT3 selectivity and potency, and this translates into differences in clinical response to the drugs, with first generation drugs needing the addition of other anti-leukemic agents to achieve clinical benefit, while second-generation FLT3 inhibitors have single-agent activity, at least in the relapsed and refractory populations. Midostaurin is currently the only multi-kinase inhibitor approved for AML in combination with intensive chemotherapy, and randomized trials adding second-generation inhibitors and either comparing them to placebo or to midostaurin as the third agent added to intensive frontline 7+3 chemotherapy have been initiated. Thank you for listening to this presentation.